Ready for another round? I can see that the participants are streaming in. Let's give them a minute and we can start. It's getting a little late in the afternoon. Maybe we cannot hope for the same level of participation in this final round. I think we could get started now. Very well. Welcome to you to all. It's great to see you on this session. It's going to be on the use of artificial intelligence-based diagnostics and prognosis. And the two distinguished speakers are Martin Steinberg and Martin Eklund. And they will now present their projects and their adventure. And please ask questions in the chat, and we will take them after the session is ended. So Martin Steinberg, I'll now assume that you will start the presentation. Please go ahead.
Okay, thank you. So my name is Martin Steinberg. I'm the project leader for OncoWatch, where we use AI to improve diagnostics and treatment of prostate cancer. And for those of you who don't know much about prostate cancer, it's the second most common cancer for men worldwide. In Europe, it's the most common cancer for men. And it's growing because we are getting older and there's a correlation between age and prostate cancer. So it's a very important cancer. The good thing with prostate cancer is that it grows pretty slowly. So if you find it early, it's basically always treatable. But if you get symptoms, it's too late. You're going to die from prostate cancer. So the diagnostic chain becomes very important. And this is what the diagnostic chain looks like for prostate cancer, basically worldwide. First, you take a blood test. It's called PSA. It's a protein marker, a blood test. And if you have an elevated PSA level, you go for a biopsy, which is basically that the doctor puts a needle up your behind to get tissue from the prostate. And then the pathologist looks at the tissue and tells you if it's cancer or not. The problem with this is that the current test is not very precise. The blood test PSA is not very precise. So it misses about 30 to 50% of all men with aggressive prostate cancer. At the same time, 4 men out of 5 who goes on for a biopsy should not have been there. So this is a test you would like to improve on. You would like to find something better. Same thing when it comes to pathology. First of all, pathologists are scarce. There's a high demand for pathology, but there are few of them. And also there's a problem with operator variability. And that means that if you give, let's say, 3 different pathologists the same 10 different samples, they will come up with very different answers. And now if you look at treatment as well, there's a lack of predictive markers. And that means that even though there are many new good treatments coming in to treat prostate cancer, we still don't know which man will benefit from what drug. What we did, we started with to improve and replace PSA with the Stockholm 3 test. The Stockholm 3 test is a blood marker. It's a blood test that is it's been tested on nearly 80,000 men. It has a very high sensitivity rate, 92%. But the most important are the bullets below. We doubled the number of men we find with aggressive prostate cancer. At the same time, we reduced the number of unnecessary biopsies by half. So it's a big improvement. We won the EIT Innovators Award in 2017. We have started selling this test in the Nordic market. Last year, we sold about 20,000 tests, and we're rolling it out worldwide right now. And this has been in collaboration with EIT Health. So it's a very successful test. So in a way, if you look at the diagnostic chain, you could say, okay, with Stockholm 3, we've solved the blood test, it's much better, but we still have the problem with pathology and treatment. And that is why we started the OncoWatch project. The OncoWatch project basically consists of 2 products, OncoWatch Image and OncoWatch Explore. And OncoWatch Image, that's basically that we have taught the computer using AI to read and evaluate scanned biopsy slide of prostate tissue. And OncoWatch Explore is what we call an accelerator for precision medicine that helps us telling what man will have use of what treatment. And in for both these products, we are using AI, but in different ways. And from here, I would like to hand over to the other Martin, and please tell us more about the actual technology behind this.
Yes, thank you for that introduction, Martin. So we start with talking about the OncoWatch Image project. And the aim here with this project is to improve on the way that we do prostate cancer pathology. Because as Martin pointed out, there's a problem with reliability in the pathology assessments. And this variability in the pathology assessments in turn translate to a clinical problem where the clinician together with the patient has to decide upon the treatment based on sort of uncertain information. So what we wanted to do with this project is to be able to develop an AI system that can assist the pathologists to do more reliable assessments of the pathology samples. And we want to do that in 3 different ways. First of all, we want to be able to predict with high certainty whether there's cancer or not in a certain biopsy specimen. And if there is cancer, we want to be able to estimate how much cancer there is. And thirdly, we would wanted to be able to assign a so-called Gleason score to each biopsy. And the Gleason score is the main prognostic marker used in prostate cancer for deciding what treatment to give to a specific to a specific patient. And thanks to the Stockholm 3 project that Martin described earlier here, we had access to a fantastic data source, actually, with a large set of biopsied men who have all been graded. Their biopsies were all graded by one single pathologist, and not just any pathologist, but a well-renowned world-class uropathologist. So he had looked at every single biopsy core in this data set. So using that data, we thought that we would have a very high chance of developing an accurate AI system. And the data looks like the image that you can see to the right here, where the purple line is the tissue specimen from a specific biopsy core from a man's prostate. And to the right, you can also see black pen marks that the pathologist has drawn adjacent to the tissue to mark where on this specific biopsy there is cancer and what parts of the biopsy there is no cancer. And using these images, we can break them up in little tiles or patches. And this is a trick that we use for creating more training data from the images that we have. So we break them up in these smaller tiles or patches, and using them, we can feed them through convolutional neural network to train this network to be able to become really good at finding prostate cancer and discriminating between benign tissue and cancer or tissue that contains cancer. And on top of that, also assign the so-called Gleason score to each biopsy. And using a convolutional or a trained convolutional neural network, we can then we can use that for making predictions based for new biopsies. And if we do that, if we use this convolutional neural network or AI system that we developed using this data and predict independent test data, it looks like what you see here on the top panel. So this is test data that was not used at all for training the algorithm, but it was still collected within the Stockholm 3 study. So it was still processed in the in the same pathology lab as we used for the Stockholm 3 study, and it was scanned on the same digital pathology scanners that we used for the Stockholm 3 project. But you can see here, it's still independent test data, and as you can see, the performance here is remarkably good. So this is a receiver operating characteristics curve to the left here, and the higher up this blue line here is on this graph, the better the discrimination capacity of the system, and this corresponds to pretty much perfect predictive performance of discriminating between benign and biopsies containing cancer. But again, this is data collected within the Stockholm 3 study. So what we also wanted to do then is to collect data from an external lab. So a new lab, or biopsies processed in a new lab and scanned on another digital pathology scanners, because we know that these kind of AI systems are susceptible to changes in the input data. So to ensure that we can have a robust system, we wanted to test it on external data, and that's what's shown here on the bottom panel. And as you can see, there's a expected drop in performance when we use it on external data, but nevertheless, the predictive or the discriminatory capacity of the system is remarkably high, and I think the area under the receiver operating characteristics curve in the top panel is 0.999, and then when we use it on external test data, it drops somewhat to 0.98, but still very encouraging results, of course. On top of that, we also have assessed this AI system's performance in terms of grading prostate cancer according to the Gleason score, and we have compared it against the so-called image-based reference panel, which is a reference panel consisting of 23 internationally renowned urological pathologists who decide upon the guidelines for prostate cancer pathology. So when we compare the AI system's grading to this set of 23 world-class pathologists, we can show that the scores assigned by the AI system are on par or within the range of these 23 top pathologists. So essentially, they have used like 30 to 35 years of their lives to become that good at grading prostate cancer, and the AI system is on par with them, which I think is a really encouraging result. So to summarize, this system can accurately discriminate between benign tissue and biopsy cores containing cancer. It can accurately do cancer localization and tumor burden assessments, and it can perform Gleason grading on par with internationally renowned experts in the field. So where do we go from here? Well, there's still research to do around that. Of course, this is very interesting and encouraging results, but what is very important to do when you develop these kind of systems is to ensure that they are not thrown off by changes in the input data. And as I talked about earlier, we tested the system on external validation data, but nonetheless, we need to do more of that kind of research. So this is to the right here, you see an image of AI system for detecting malignant melanoma in skin lesions, photographs of skin lesions. And to the left, the image to the left is predicted by the system to be a benign lesion, but then by adding just random white noise to this image, and you get an image looking like the one to the right here, which to us humans look exactly the same, but the AI system is completely thrown off by adding this kind of white noise to the image, meaning that instead of predicting it as benign, it's almost 100% sure that this is actually a malignant skin lesion. So this is the kind of adversarial behavior that we need to protect the system against, and that's what we do in this OncoWatch image project, which is funded by EIT. So within this project, we collect data from a large set of pathology labs across Europe and scanned on very many different digital pathology scanners, and also containing a very wide range of different morphology of prostate tissue. And using this data, we can adapt and protect the system against this kind of behavior where it is making incorrect predictions because it's exposed to data that it hasn't seen before. So this is a really key component in the development of these kind of systems. The last thing that we wanted to talk about here as well is a project that we called OncoWatch Explore, which is, like Martin mentioned, a way of developing an assay for optimizing treatment for men with metastatic prostate cancer. So men with metastatic prostate cancer, they will die from their disease, unfortunately. But of course, by using the correct treatment, we can make them live longer and with high quality of life. And that's the whole purpose of OncoWatch Explore. So in Sweden, we have about 2,500 to 3,000 men who develop metastatic prostate cancer every year. And there is a set of relatively new drugs that are effective against this patient population. But the problem with these drugs is that typically only about 25 to 35% of the patients respond to each drug. And that creates like a trial and error process where the physician tries to find the right treatment for the right patient. So there's a need for predictive biomarkers for this patient population. And it should also be mentioned that these drugs are very expensive. So it's critical that you select the right treatment also from a health economical point of view. And what we hope then to do to show with OncoWatch Explore is that instead of using this sort of trial and error process of finding the right treatment for the right patient, we want to base the treatment decisions on a genomic profile of the tumor. So what we do is that we draw blood from the patient and we amplify circulating tumor DNA from this patient. And thereby we get a snapshot of what the genomic profile looks like in the patient at that particular point in time. And we use that for administrating the treatment. And this is sort of a liquid biopsy concept where the tumor releases DNA into the bloodstream when the tumor cells die. And therefore we can, by a simple blood sample, get a genomic picture of what the cancer looks like. And we're testing this we're currently testing this in a multi-site international platform trial. So this trial is now ongoing in Sweden and Belgium, and it's opening in Norway and Switzerland as soon as possible. It's been delayed, unfortunately, a few months due to COVID. But this trial is I think really quite cool because it creates a learning system in and of itself, where the whole design of the trial is to figure out which genomic profiles go together with which treatment to create the best possible response rate for the patients. So what we do here is that we draw blood on the patient entering the trial, and based on this blood draw, we get the genomic profile, and then we assign different treatments based on the genomic profile of the cancer. But the thing here is that when we collect data within the trial, these randomization probabilities will adapt and change throughout the course of the trial, so that the whole trial becomes a learning system to ensure that you get the right treatment for the right patient. And this is also like a real world application of reinforcement learning, which is also an AI concept that has been applied a lot for developing, for instance, robots, where you need to balance between exploitation and exploration. So exploitation is using the knowledge that you already have about a system for making the correct choice. Whereas exploration is when you try to gain new knowledge. And what we do here is by assigning or by morphing or changing and adapting the randomization probabilities is to, in an optimal way, balance between exploiting the data that we already have collected in the trial, and exploration to learn new things about the combination of specific genomic profiles and treatments. So that's what I wanted to say with respect to OncoWatch Explore and OncoWatch Image, and we are happy to answer any questions now. Thank you so much.
Thanks a lot, Martin. And Martin, Thanks for this excellent presentation. I mean, what a fantastic journey, and what an amount of success you have received now. And I have to build on a question which was placed in the chat that obviously springs to mind. Do you see the limit of this technology? The OncoWatch platform can be used for diagnosis and prognosis of other cancer diseases as well, like malignant melanoma, breast cancer types, or less common types of cancer?
Yes, so both of these kind of systems, OncoWatch Image and OncoWatch Explorer, are of course completely adaptable or to other cancer types as well. And we have started with prostate cancer because that's where we have sort of the foundation for our research, and in the contact with clinicians and the healthcare system in general, that's how we recruit our patients. But of course, there's nothing in this technology that is restricted to prostate cancer, but the whole concept can of course be generalized and applied in other cancer types as well.
Okay, I see there's also some questions popping up in the Q&A. Maybe you can address those yourself.
Yeah, I think I'll let Martin, if you answer those, I think you're the best one to answer.
Yeah, so the first question here is about generalizability, and that the data that we use for training, I suspect that you are referring to the OncoWatch Image system here. Yeah, this is of course a very good question, and in fact this is what we are trying to address in this EIT-funded project that we're discussing here, is to really be able to collect data so that we can ensure that the predictions from the algorithm are generalizable across different labs, different populations, and different scanners used for scanning these images. But this is really a key concept. And if we talk about the Stockholm 3 test, we're now also testing this in multi-ethnic cohorts in the United States to ensure exactly the same thing, because this is fundamentally important, I think. But I think in a way it's actually easier for OncoWatch Image compared to Stockholm 3, because I think from a morphological point of view, it's less likely that there are any differences between, for instance, let's say African American men and white American men, for instance. I think on the tissue level it will look very similar, but it remains to be tested, of course. The second question here, do you have included lung cancer patient data? No, we have no data, unfortunately, on lung cancer, but of course it's a very important cancer type as well, and it would be really interesting to do those kind of studies as well. But I think a key thing here, in order to be effective, you need to somehow also concentrate on one disease area, or at least you need to somehow limit yourself in order to be able to have bandwidth to do the critical things that you need to do. So we have not tested lung cancer at the moment. How do we recruit patients? Only from Sweden? No, not only from Sweden. We have for both of these projects, we are expanding internationally, both in Europe, and for the Stockholm 3 project, also certainly in the United States now. So we have started in Sweden, of course, because this is where we live and reside, and this is where we have good access to patients and very good and efficient collaborations with the healthcare system. But of course, the end objective is not to have this be Sweden specific, but instead generalize it so that it can be applied within Europe and internationally on a global level.
Very nice. I actually also wondered, I don't think I've ever seen such a complex clinical trial setup as the one you just showed before. And I obviously don't want to go into the details, but can you just briefly explain some of the challenges of running such a trial? I mean, the ProBio trial that you just showed before.
Yeah, absolutely. So yes, you're right. It is a very complex trial, and it requires a lot of planning and a lot of both on the statistical side, for instance, how you design a complex trial that's like this. Only that part of the problem is complicated, and then how you engage and with all of the regulatory bodies in all of the countries at the same time across multiple drugs is also a very complicated problem. But I think it's also an opportunity and an advantage in the end, because what we want to do in the end of the day is, of course, to have something again that is generalizable and that can be implemented on a global level, and addressing these kind of challenges upfront within the clinical trial and within the development of this this assay that we hope to become a successful product in the end. Thereby, I think that and also getting all of the necessary stakeholders involved in this trial already upfront. Thereby, I think we will have a quicker route to implementation and global sort of reach with this kind of complicated trial design. So I think, yes, it sort of front loads the challenges, but in the end, I think that it's going to be instead catalyzing the way that we can reach clinical implementation.
Yeah. And also, you talked about the Gleason grading quite a bit. There's the common way of grading cancer cells. But do you think that this will somehow lead to a situation where you could go beyond the Gleason grading and even improve prognostication even further?
Yes, I do think that. I think there are challenges, of course, in doing that. This is something that pathologists have been working on since the 60s to sort of refine the Gleason grading system and getting it to have a higher association with hard final outcome of the disease. But I really think that the next step when it comes to extracting morphological information from the biopsy specimen can really be taken with artificial intelligence, because that provides a way of directly linking morphological information to final outcome data. And there are numerous challenges in doing that, and I don't have time to go into those. But the way I see it is that we can build on the system that we have now and then apply techniques like transfer learning to sort of retweak the system that we have now to be able to better predict final outcome. And we are, of course, exploring that, of course, as well, using data from, for instance, the Stockholm 3 study, and also in collaboration together with other researchers who have cohorts with longer follow-up time. So this is a super interesting avenue for an opportunity for improvements, for sure.
That's great. It seems that the adventure goes on, and it also seems that we are running out of time now. So thank you, Martin and Martin, for your presentation. It was brilliant. And also thanks to all the listeners. I hope you enjoyed it. Please stay in touch. Contact us. We are all available for questions and further discussions at any time. Thank you very much for now. Bye.
Thank you so much, everyone. Bye-bye.
Thank you.